Hi, I'm Dr. Rajan Sagar from the University of California, Los Angeles. The question in front of us today is what evidence supports the use of combination therapy in treating connective tissue disease, PAH? The rationale for this is very simple. There are several short-term monotherapy trials which certainly led to FDA approval of several of our FDA-approved medications. However, it is very clear in the analysis of many of our studies that the connective tissue disease subgroup tends to fare worse than the idiopathic arterial hypertension counterpart in terms of response to therapy and functional capacity improvements. As such, one of the studies that must be highlighted in terms of a combination approach is the AMBITION study. Again, the rationale for which was that asking the simple question, which is that if you introduce two therapies up front as initial upfront combination and compare this to monotherapy arms, so two monotherapy arms compared to the combination using tadalafil and ambrisentan, could you actually improve morbidity and mortality as the primary outcome? And the primary endpoint in this study, to be more specific, was time to first clinical failure event, which included either first occurrence of death, hospitalization for worsening PAH, disease progression, which had a clear definition which we can review, or unsatisfactory long-term clinical response. In this study, what became very clear and was highly statistically significant was that in the combination therapy arm, in the systemic sclerosis or the connective tissue disease PAH group, there was a clear improvement in event-free survival in the group that was receiving combination therapy versus the pooled monotherapy arms. And you can see in this Kaplan-Meier event-free survival curve, this was out to approximately 168 weeks. So this next slide really breaks down the events for us in terms of the morbidity and mortality endpoint. And you can see that for all 6 endpoints that were part of this combined morbidity and mortality endpoint, there were clear improvements or trends to improvements in the hazard ratios that favored combination therapy compared to monotherapy, as you can see in this nice table and graph. And you can see here that if the line is towards the left of the vertical hatched line, it favored combination therapy, and to the right favored monotherapy, again supporting this prior statement. So in the subgroup analysis, the summary of the use of combination therapy, specifically tadalafil and ambrisentan as upfront combination in this study known as AMBITION, in the connective tissue disease pulmonary arterial hypertension subgroup, favored the use of combination therapy over the pooled monotherapy in terms of patients with systemic sclerosis and PAH. And there was a greater improvement in the plasma NT-proBNP as well as the functional capacity based on 6-minute walk distance in combination therapy compared with monotherapy. And there were no safety signals identified of concern in the connective tissue disease PAH subset, although there were some adverse reactions that appeared more frequent in the connective tissue disease PAH group compared to the other PAH subgroups, such as diarrhea and anemia, possibly due to the coexisting connective tissue disease. So in summary, the more aggressive treatment algorithm of upfront combination therapy, particularly in the connective tissue disease, systemic sclerosis, PAH group, may be of significant benefit. Moving forward, the next clinical trial that addressed combination therapy was the Seraphin study, which looked at the use of macitentan added often to background therapy in approximately half the cohort compared to placebo, and looking at a very similar morbidity and mortality endpoint in PAH. And specifically in this graph here, you can see that in the connective tissue disease PAH group, which represented about 1/3 of the patients in the Seraphin study, the time to the first PAH-related hospitalization was significantly improved in the group that had macitentan compared to placebo. Moving on, in the Griffin study, where we studied the use of selexipag, again, versus placebo in a very similar, again, morbidity and mortality endpoint compared to placebo, you can see that patients without an event, again, in the connective tissue disease pulmonary hypertension subgroup, favored the use of selexipag versus placebo, again, either as monotherapy or as add-on therapy in this study. And This represented a 40% reduction in the combined morbidity and mortality endpoint in the selexipag group, which was statistically significant. So the takeaway message from all of these combination studies, most of which were either add-on therapies to often background therapy, is the concept that combination therapy in the subgroup of patients with connective tissue disease-associated PAH often was superior in terms of the combined morbidity and mortality endpoint. Thank you.